this computer. Okay, yep, and we're recording. So we'll go ahead and get started. Design and slideshow. Everyone can see the PowerPoint? Good. If you can't, let me know, speak out. It doesn't let me go backwards, so that's the hard part. So if you are still trying to write down stuff, I'm going to keep moving on. Stay after and let me know if we need to go back to that slide or if you're missing something, okay? So we're going over diabetes mellitus. This is geared towards LPN and level 2. I want this to go away. So diabetes mellitus, it's a chronic multi-system disease. It's related to either the body can't respond to insulin normally, or the pancreas actually shuts it down altogether and doesn't make any more insulin. Diabetes is the 7th leading cause of death in America, and it's the leading cause of adult blindness, end-stage renal disease, and limb loss that isn't from trauma reasons. The 2 most common types are type 1 and type 2. You will also learn about gestational diabetes. I will not be going over that because that's pregnancy stuff, and I want to make sure to cover this topic. You will learn about gestational diabetes later, as well as it is a little bit in your reading. So we need to know normal before we learn abnormal. So a lot of times people don't understand how insulin works. So the way insulin functions, it's secreted by your pancreas, by the beta cells in the islet of Langerhans, whoever decided to name it. Either way, it's released by those cells, and it constantly keeps your sugar level in your blood between 70 to 110. Sometimes your sugars tend to spike up after you eat, but then insulin comes in and helps move that sugar into the cells. Your sugar doesn't go automatically into the cell. Insulin is the one that helps move it in. So insulin takes down your sugar levels. There's other hormones that help increase your sugar in times of need. So some of those hormones that increase your sugar levels are cortisol, glucagon, growth hormone, and epinephrine. So just think about when you're really stressed or like your fight or flight response, your body's going to send off a mass amount of sugar because it wants more sugar in your bloodstream, so then your body will use it. There are different types of tissues that don't need insulin and then some that do. Tissues that do not need insulin is your brain, liver, and blood cells. If any of y'all been studying late at night, super duper tired, and the first thing you keep thinking about is eating really sugary things, that's your brain telling you need more energy. Your brain, liver, and blood cells do not require insulin. The bodily tissues that do require insulin to use glucose is your skeletal muscles and your fat tissue. So I'm going to move on to the next picture. It's a better view. Why it won't move. Sorry, I'm going to have to back out of this. Stop share. Sorry guys, it'll do that to me every so often with my PowerPoint. I'm not sure why yet. Share screen. Here. Share. There we go. So this is kind of a better image. So the insulin receptors will bound to insulin, gates will open up, and glucose will move into the cell. Again, this is your skeletal muscle and your fat tissue that require insulin then to use up the glucose. So diabetes mellitus, the diseases are the fact that you don't have adequate insulin, or the cells are no longer sensitive to that insulin, and we'll go into depth about that. There you'll hear the insulin's the key for glucose, and that's why. Okay, so more insulin functions. Again, you need to know normal before you can know abnormal. This stimulates the storage of glucose from as glycogen in the liver and muscles. So when you want to respond quickly or your blood sugar drops, your body wants storage amounts so then it can release it. So insulin helps storage it. Remember, glycogen is the storage unit of glucose. It inhibits glycogenesis, which is the making of glucose after meals, because it wants to utilize the glucose that you just ate. After meals, insulin will actually enhances fat deposits of the fat tissue. It doesn't understand that maybe you want to lose the weight, it just automatically starts storing it. It also increases protein synthesis after meals. And during times of fasting, like overnight when you're sleeping, it helps release glucose that was stored in your liver and protein, and then it can reuse it for fuel into our cells. So that's some of the insulin functions. So now to go into diagnostics, I'm not going by the book order. NIP has a handout for diabetes, and I try to line it up as much as I could. So then if you're using that handout, it goes along with it. So there is such thing as pre-diabetes. This is when they have a flat fasting blood glucose, and it reads at 100 to 125 milligrams per deciliter. So fasting means that they haven't eaten for 8 hours, then they go to the doctors, and that's what their sugar level is. It shouldn't be above 110 after not eating for 8 hours. Then an oral glucose tolerance test. Basically, they give you a certain amount of sugar, and then you wait 2 hours, and then they'll test your sugar. And so if it's between 140 and 199, you are then termed pre-diabetic. So you're not full-on diabetic yet, but you are definitely at risk of becoming a diabetic. And that's usually type 2s. These people don't usually have symptoms, but the damage that occurs to the organs like the eyes or the kidneys are already occurring, could be. Alrighty. So I'm sorry, I know it's a lot of words. We'll get through it. So this is for actual diabetics, like when they are diagnosed with diabetes, this is the diagnostic testing. So there's this term called the hemoglobin A1C. This is a diabetic's report card. So some diabetics will go to their doctor's office and they'll eat really well the morning of, and they'll check their sugar and they're like, look, it looks great, it's in the 90s. Then you pull up their A1C and that will be like 11. I've had patients have huge A1Cs. Normal should be like below 5, if I remember. But basically what's happening is that the sugar levels in the blood, the glucose levels, are so high that the body is forcing it into the red blood cells. Because remember, your red blood cells don't need insulin to use up the glucose. So this glucose is just pushed onto this red blood cell. And so that A1C measures how much glucose the hemoglobin or the red blood cells carrying around, just because the body was just trying to get rid of how high it was. So again, it's its report card because that measures about 120 days. So that tells you for how good were they for about 3 months with their diet or their plan of care that you were doing for them. I've had patients with hemoglobins of like 11, 12, so you can only imagine how much sugar was being forced onto that red blood cell. And then you have a fasting plasma glucose level greater than 126. Again, fasting means no caloric intake for 8 hours. And then you have the oral glucose tolerance test, where they check your plasma blood glucose, and it's more than 200. That's after you ingest 75 grams of glucose and you hang out in the doctor's office, and 2 hours later they check you. If it's over 200, you're a diabetic. And then, so from 1 to 3, those numbers there, those diagnostic tests, that has to be repeated to confirm diabetes. The number 4, the last one, you have the classic signs and symptoms of hyperglycemia, which we will go into later, or they're having a hyperglycemic crisis, and then during that time you do a random blood glucose and their sugar is more than 200. So number 4 does not have to be repeated, that 4th one of having the signs and symptoms, but 1, 2, and 3, they do need to be repeated to confirm. Okay, going to move on. So now we're going to go into the different types of diabetes. Type 1 diabetes, this is an autoimmune disease where the body just makes antibodies that will fight against the beta cells in the pancreas. So then they end up dying off and they completely stop functioning at a certain point, and it can no longer produce insulin, or it actually works against the insulin. This used to be known as juvenile diabetes because it does tend to happen when they're younger. Then they found there is something called latent autoimmune diabetes in adults. So that LADA, that is type 1. That is type 1 diabetes that occurs later in life. They just always assumed if you were older and you got diabetic, it was type 2. They found out that's not true. And then idiopathic diabetes is a form of type 1 that's inherited, but it's completely unrelated to the autoimmunity. You guys already had your immunity lecture. So autoimmunity just means the body attacks itself. So type 1, the body ends up attacking itself, and basically the beta cells no longer function. Very little insulin is produced in this. So you're going to have patients, typically younger, who will come in with these clinical manifestations. These are very key characteristic clinical manifestations. Polyuria is peeing a lot. Polydipsia is being super thirsty and drinking a lot of fluids. And polyphagia is being hungry constantly. These three occur because polyuria occurs, which is peeing a lot, because there's so much sugar in your blood that end up going to your kidneys, and the sugar just has such a high osmotic pull that it pulls all the fluid in, it's making them dehydrated. So then that makes them thirsty on top of it. So then that's the polydipsia. They're super thirsty because they're becoming dehydrated because they're peeing out almost all their fluids as well as sugar. Whatever your body wants to get rid of, it will always go through your kidneys, almost guaranteed. You'll be peeing the excess of it. So you're peeing out excess sugar, which is not typical. Then polyphagia, your cells are still very hungry and they don't know why they're not getting enough energy. You don't have insulin, which means glucose is not going into the cell, which means your cells are completely depleted of energy. So it keeps telling you to eat, keeps telling you, hey, I need to eat. You need energy. It just doesn't understand that you don't have insulin to utilize the glucose you're eating. These people will have weight loss because over time, the body will start breaking down other forms of energy, such as fat and muscle protein. They'll have fatigue, weakness, blurred vision, headache. NV is nausea, vomiting. You're going to see some shorthand in here if you don't understand. Please speak up, because that probably more than one of you don't know shorthand. You'll just see it more and more often as you go through the program. So NV and ABD just means nausea, vomiting, and then abdominal cramps. And glucosuria is the sugar in urine. So for type 1 diabetics, I can't stress this enough, they will require outside insulin, exogenous insulin, for the rest of their life. Their need amounts may change or fluctuate, but they can only get insulin. That is their only option. Alrighty, because you're learning PO meds currently, and they can't have that. They cannot have pills. They need to have insulin, unfortunately. I don't know why it's doing this every time. Sorry, guys. Is not dealing with.
It's not allowing you to go next?
No, it did this to me when I did the cardiac one. It will just randomly pause, and then I can't. So I just got to keep doing that. So concurrent slide. Oh, no. Okay, there we go. Anyway, if anyone's come in late, by the way, oh, I see. Could you guys please type in your student numbers if you guys haven't figured that out yet? That we have to enter in a lot of info and make sure we know who's coming in or not. As well, that does help you later, because if you showed that you went and got extra help and you're having a hard time later, the professors or chairs absolutely look at that, by the way. So it's always good to know if you are coming to NIP and put stuff there.
I just have I'm
Yeah.
so sorry.
No, you're
So,
fine. Go ahead.
so type 1 does not get oral pills, just insulin?
No, absolutely not. Almost
Great.
all oral pills, which will go in a little teeny tiny bit, they work on a little bit of insulin that the body's producing. Type 1s, no insulin, almost none, it's gone. So pills are only for type 2 diabetics. That's it.
Thank you. Yeah.
Yep. Alrighty, so keep going for type 2 diabetes. So this used to be believe that this is just for adults. So over time, either the cells became insensitive or the pancreas isn't producing enough insulin. There's still some, but it's just not near enough to what's going on. So that's why you see insulin resistance, or the body's not using it properly. This is usually a gradual onset, where type 1 would be quicker because their cells just start getting attacked and then they kind of just have no more insulin. So type 2 is a gradual increase. There are some risk factors to it. There's family history, obesity, and being older. Can't change much about that except for like your obesity thing. Clinical manifestations. They may still have the classic signs and symptoms of the polyuria, polyphagia, polydipsia, so the Ps, but they will also experience more or less delayed wound healing, recurrent infections, fatigue, and visual changes. High sugar in your blood is basically like tiny shards of glass. I had a student who heard that somewhere, and it's very accurate. So very high sugar levels is very damaging to your blood vessel and your nerves. So that's why when you have a wound on your foot, if you're a diabetic, it's really, really bad because you're going to have really poor blood flow to that area. So they'll be like, oh, I went to the beach, and they're like, my foot hasn't healed in like a month. And you're like, oh, crap. Okay. So then you start testing for diabetes. That's usually what they'll come in with for type 2s. Recurrent infection, females, they'll have the yeast infection constantly. And then fatigue and visual changes is due to high sugar levels. Your brain can't usually sustain that as well. So for treatment for type 2, you're going to start with lifestyle changes. You're going to start with PO medications, the pills, and then if that doesn't work, yes, they're going to move towards insulin. But you're always going to encourage lifestyle changes before this, because that's usually, there's people out there who say like they've cured their type 2 diabetic. They cured themselves by losing weight, and studies do show you can help yourself a lot if you do. Oh man, this is gonna be a pain in the butt. Alrighty. So I'm gonna see.
May I ask a simple question?
Yeah.
Where can we find the PowerPoint? Can we find that?
I made it. I have to have y'all's faculty approve it, which can take a hot minute, if I'm gonna be honest. And I'll ask Lisa if she can find out and send it, but it might be a while before I can actually send this out to anyone.
Okay, I really like it, and it's very simple.
I made it myself, so I try to make all my own stuff and go through it because it helps me retain things as well. So I'm gonna see if I can do this and if this helps.
Can I ask something as well?
Yeah.
So this is recorded and it's going to be in the course, correct?
Correct.
What like section is it going to be under, so I can just find it? Because I have to go to a meeting in a minute. Oh,
sorry, I won't know. That's all through Lisa. They upload this. I'm part-time with y'all. So I don't get to even see any of your stuff. I can only see what's posted on my courses. So I would get with your professor and find out where it'll be uploaded, okay?
Alrighty, thank you.
That or Lisa is the director for NIP. She'll know.
Thank you.
No problem. So
is this gonna help you? If you want, you can send it to me and then just do it. I can just pass it on for you.
I'll try. We'll try. The first time I tried to upload something from EKG, it didn't come up right. So they had to do some type of upgrade for my thing. So we want to make sure everything's going. So I'm going to keep moving on. I promise this stuff will be posted up on my courses because I think my EKG did as well. And my colleagues got my video as well. So I'm going into signs and symptoms of hyperglycemia and hypoglycemia because you're going to hear me talk about it, and I don't want you to be like, crap, what is she talking about? And then we'll go into treatments and acute problems later. So hyperglycemia, again, that's a very high sugar level. It's typically over 110. Your signs and symptoms we talked about, I can't stress these enough, is polyuria, polyphagia, polydipsia, weakness, fatigue, blurred vision, nausea, vomiting, abdominal cramps, and glucosuria. Some causes of this that, other than like just being a diabetic, can be the use of steroids, corticosteroids, because that increases cortisol levels and your blood sugar levels. Not enough insulin when they're sick. Your sugar levels go up when you're sick naturally, so they may not be used to that, and they keep taking their normal medications when they're really sick. Infection, stress, so you guys probably have high blood sugar all the time, by the way, being in nursing school. And then inactivity as well, because when you eat and then don't move around, when you walk around and stuff like that, your body will use up that sugar. Insulin will help facilitate you use it when you use the energy in your body. Then the next slide. Does anyone know RN nurse, what is it, registered nurse RN? Her little videos. Everyone can see my PowerPoint, right? Because for some reason it won't let me keep doing the slideshow. Right here, this has saved me so many times, but it works. So when your patient's hypoglycemic, this is a blood sugar less than 70, their signs and symptoms are cold, clammy skin, tachycardia, or I've also read palpitations somewhere, numbness in mouth, fingers, and or toes, tremors and nervousness, dizziness, changes in vision, unsteady gait, hunger, and slurred speech. So I kind of think of like a drunk person, sorry. And then seizures and coma, that's really late signs. But this registered nurse RN, if you guys are into watching videos to help, she has tons of videos that are really good. She has a really thick Southern accent. So something that she coined that I hear all the time, and I've used this on so many tests now. If your patient is shaky, cold, and clammy, give them some candy. Okay? And she has a really thick Southern accent, so it makes me laugh all the time. But shaky, cold, and clammy, give me some candy. Those are signs of hypoglycemia. And then you need to be careful if you have a patient who is diabetic, or even if they're not a diabetic, but they're taking beta blockers, those LOLs, metoprolol, atenolol, those medications specifically mask the signs and symptoms of hypoglycemia. So your patient can be like tanking in the 30s and they just looked fine before, but you're like, oh crap, they're on a beta blocker. So half the signs and symptoms you're used to seeing, they're not going to show. Okay, so you need to remember that beta blockers will mask signs and symptoms of hypoglycemia. Alrighty, and then now we're going into insulin. Yes, you do unfortunately need to know the time frames. I am very sorry, it does suck a lot, but you get used to it over time, and it does get easier. I'll tell you that. So you have insulin, you have rapid acting, you have the Lispro, Aspart, and glucine. I'm gonna mess up these names so bad, so don't think I'm saying them correctly. And then so the way some people remembered these is from the commercial names, the Humalog and Novolog. Just imagine a log rolling down a hill. It's super quick. I didn't really like that. I always thought Lispro and Aspart are really short names, really rapid, really short names. So that's how I remember it. The onset is 10 to 30 minutes. Your patient needs to be eating within 15 minutes of giving Humalog or any of these insulins. You can't give it like an hour ahead because they're gonna tank on you. You're gonna be really screwed. And then peak is 30 minutes to 3 hours. And then duration is 3 to 5 hours. This is for mealtime specifically. This mimics the body's natural response to when you eat. When you eat, your sugar goes up. And then your pancreas, your beta cells release insulin, so then your cells can use that sugar. So that's the point of doing this rapid acting, and this is specifically with meal times. Like this, I can't even pull any of this until 30 minutes before I know a meal's coming on the floor. Whoops. Forgot I am not in slideshow mode. delete. All right, so then you have your short-acting insulin. This is regular insulin. This is the only insulin that can be given IV, and this will come up later. You should give this about 30 to 45 minutes within a meal. The onset is 30 minutes to an hour. Peak is 2 to 5 hours, and duration is 5 to 8. If I didn't say this before, during the peak times of insulin is when your patient is most at risk of having a hypoglycemic episode. So if you just gave insulin and say you notice the meal trays aren't there yet, and you're like, oh, and you go look at your patient, sweaty, cold, you better go give them a snack, go check their sugar, stuff like that, because that peak time is when they're most likely going to be hypoglycemic. And then you have your basal insulins, which is basal is like your body naturally will constantly be secreting insulin all the time, 24/7, just a slow little amount. So these insulins help mimic that. So you have a slow or low amount that's constantly in your blood to help facilitate glucose moving into the cell at all times. You have intermediate action, which is NPH. Don't ask me what it stands for. I just know protomate's the P, and I always remember that's a protein, and that's why that's cloudy. So quick tip, if you are about to give NPH, you gently roll the insulin in your palms prior to use. It's just to mix up the protein or the cloudiness that you see in there. Protein, the cloudy is normal, and that's okay. So onset for this is 1.5 to 4 hours. Peak is 4 to 12 hours, and then duration is 5 to 8 hours. Long acting, I always remembered these weird names are really long, and they're long acting, so that's how that worked for me. Glargine, which is Lantus, Ditromir, which is Levemir, and then I don't even see this on the floor usually. I'm just gonna call it Trespa because that's the nicer name of it. This has an onset of 0.8 to 4 hours. There is no peak. And then duration is 16 to 24 hours. So I'll see patients, I'll give them Levemir in the morning with their 9 o'clock meds. I'll give them the Lispro at 7:30 before 8 o'clock meals. Then I'll give them Lispro every meal, and then they'll get another night dose of Levemir or something like that. So they can have combination of any of these insulins to help facilitate a normal blood glucose level as much as you can. And then if you do not, I have never had to draw NPH into insulin before, like on the floor. But you, unfortunately for testing purposes, will need to know the order that you draw up the NPH and you mix with insulin and stuff like that. I always remembered Nancy Reagan RN. So it's NPH, regular, then regular NPH. All right? Because you will need to know that. So some tips about insulin storage, because you will have to teach your patients on how to do that. So if the insulin's being used, because it's in teeny tiny little vials, and if the patient's using them, that can be out in room temperature for 4 weeks. Then if they are traveling to a hot climate, such as us, hitting over 100 degrees today, I'm not a fan of it. They can keep it in a thermos or a cooler. They can't keep them frozen though, just a thermos or a cooler to keep them at a normal temperature. Stored unopened vials or pens can be in the refrigerator. Pre-filled, if it's one insulin, pre-filled mixed insulin mix. So if it's multiple different types of insulin in one vial, can be 1 week. Pre-filled single insulin is 30 days. Then you can store your syringes in a vertical position with needle pointing up. I did not remember that key tip, and that did come back to bite me in like my later times in like 3 or 4 because it's such a random little thing. But yes, doesn't make sense to me, but needle up. And then before you use it, if you've taken it out of the fridge, gently roll the syringes between palms to warm up insulin. Don't vigorously shake this medication. So some problems with insulin. People can have allergic reaction to it, either to some of the properties that's in insulin. They can have itchy, burning, or redness around the injection site. This will go away after a couple months, or they just start taking it with antihistamine. See, because like if you're a type 1 diabetic, you can't just be like, well, I don't really like it. You know, I get a little itchy there, so I can't take it. They'll die. So you teach them to take antihistamines with it. And then lipodystrophy is changes to sub-Q tissue. This could be most likely lack to a rotation in site. And you guys learned how to give insulin last semester, or you've given it before. It's always in the sub-Q area. They should not work out, and like if they give it in the arm, they give themselves insulin in the arm, they should avoid working out right after, because that increases the speed of absorption to the body. So they need to be aware of that. And the abdomen is the fastest area like that absorbs when giving insulin. And they should do it like a checkerboard and keep rotating sites as they go, or else this will occur. And it can either thicken or deplete in the lipid area. And I'm not really sure if it ever comes back. I haven't figured that out yet, but yes, that is what it can look like. So now we're going to go into other problems with insulin, Somogyi effect versus Dawn phenomenon. And I do apologize by how much wording is in some of these, but it's the only way to get it as we can do. So I'm going to zoom in a little bit. So for Somogyi effect, because you've given them insulin, their sugars will drop between 2 a.m. and 4 a.m. and it'll drop so much that the other hormones like epinephrine or cortisol will increase your blood sugar, will increase their blood sugar. So then when I come in the morning, we check their sugars and now they're sky high. Now they're like 200, 300, and you're like, holy crap, okay. And you got to figure out why. Complaints patients may have, or signs and symptoms you're going to see, is they'll have signs of hyperglycemia in the morning, but in the middle of the night, they'll be hypoglycemic. So they're going to have complaints of night sweats, nightmares, or headaches. Again, this is a problem that their blood sugar drops too low in the middle of the night, and their body's reaction is to crank up the glucose a lot, increasing it. So what do? If you keep seeing your patient has sky-high sugars in the morning, before you let your doctor order more insulin the evening prior, you check their sugar between 2 to 4 a.m. Because you're going to rule out between Somogyi effect or Dawn phenomenon. The one we're talking about now is Somogyi effect. So if it is a Somogyi effect, in the middle of the night, their sugars will be very low. So then you tell the doctor, hey, we shouldn't increase their insulin. That's going to make things worse. What you're going to do, you should lower the evening insulin dose and or provide a bedtime snack. Again, this is just the body's reaction to when they start getting insulin. So I always thought Somogyi effect, SOMO goes low. Because the Dawn phenomenon is like the opposite of this. So SOMO goes low. And then back, try to reason out. And then you have this is the Dawn phenomenon that I'm talking about now. So same thing, you've given them insulin, but in the middle of the night, growth hormone and cortisol starts excreting itself crazily, and now they're hyperglycemic throughout the entire night, specifically at like 2 in the morning. So again, you'll come in the morning and their sugars are sky high at 7 a.m. You're going to want to check their sugar between 2 to 4. If it's very high, that means they have Dawn phenomenon. As well as they might have some of the signs of hyperglycemia, the polys, polyphagia, polyuria, polydipsia. And then, so when you find out they have Dawn phenomenon, what you're going to do is increase the evening dose of insulin. Okay, so Dawn, they constantly are high in the middle of the night, and Somogyi, they drop low in the middle of the night. Because you're definitely gonna have questions, either not semester or in the future, you will definitely have questions on how to figure out between Dawn phenomenon and Somogyi effect and what to do. Okay. So now, this is this is like a lot in one slide, and I do apologize for that. I'm gonna go to current slide so you can see it better. Damn it. Okay. Because we don't have enough time to go through every single PO medication and its action. Just know that type 1s cannot take these meds. And so it's going to be type 2 diabetics that will take these. It's you're always going to encourage diet and exercise as well as these medications. These pills are not going to just fix their problem. All these pills or medications, they work on some hope, or that the fact that the body makes some insulin still. Type 2 diabetics still make some, or the body just isn't, the cells aren't sensitive to the insulin. So there is circulating insulin to work with naturally. And that's what these medications work on. So you have biguanides or metformin. If this, again, I'm doing like the key highlights that you absolutely will see later about questions for these. Not now, but probably later. If someone's taking metformin, they cannot have IV contrast. This will kill their kidneys. They'll have AKI, which is acute kidney injury. And then they should take it with meals to reduce GI symptoms. If a patient's going to have GI contrast, they need to be off metformin for 1 to 2 days prior, and then off of it for 48 hours after the procedure or wherever they got the contrast for. So for like 4 days entirely, they need to be off metformin if you want to do IV contrast. Then you have, as well as they should not drink alcohol when taking this. People who damage their liver or damage their kidneys should not be put on metformin. And that's for most of these meds as well, because a lot of them are excreted through the kidneys and they're metabolized through the liver. Then you have sulfonylureas. I remember these as they ended in ides at the end. Glipizide, glyburide. Like, they have really funky names, but luckily most of them ended at ide, IDE in the end. You cannot drink alcohol. ETOH is alcohol in shorthand. With these meds, they will have severe flu-like symptoms, or disulfiram effect is the other term. And then, as well as, you should check for allergies. All the time when you give meds, you should check for allergies, but there are sulfa antibiotics that if they're allergic to that, they can't take these meds. So you need to check for a sulfa allergy. You have meglanides, which is, they end in glanides. Again, I'm not very good with these names, but like natglanide or Starlix. These are rapid acting. They have to be taken with meals. So if you skip a meal, you skip this med. You really shouldn't do that if you're diabetic, but they have to take this with meals. They can't just take it on an empty stomach or not going to be eating soon. Then you have your alpha glucodase, glucosidase, which is like a carbose, or meglitol. These are starch blockers. So again, if the whole point is to block the reuptake of carbs or starch into the body, you should do that when you're eating them. So take this with meals. You take this with the first bite of the meal, and then side effects are flatulence and diarrhea, because basically you're not going to absorb it, so it's going to come out some other way. Then, oh Lord, thiazolidones, diodones, sorry guys. This wasn't in the handout, but I did have to learn it, so I added it. So rosiglitazone, this medication can cause fluid retention and edema. So this is contraindicated for patients with heart failure. Again, type 1 diabetics cannot take these. Patients should have adequate kidney function and liver function, which you monitor on labs, the BUN and creatinine and the LFTs, as well as if someone's taking these meds, you should monitor them for hypoglycemia, shaky, cold, and clammy, because some of these meds can put them at risk of going into a hypoglycemic episode. Alrighty. See if it works for me. Nope. There we go. And then next slide.
You're awesome, by the way.
Thanks. I'm gonna have to keep chugging away. But thank you. If you guys have any questions, you guys are allowed to perk up at any time and ask. If I think I address it later, then I'll tell you, well, just hold on to me. Hold on for a minute, and then if I don't think so, I will try to answer it then. So this is some extra miscellaneous teaching, because this chapter is 30 pages long, but there's a lot of teaching for diabetics. So nutritional therapy. Of course, the type 2s should try to lose weight. They should try to eat well. They should try to do some exercise. The key thing is to try to follow my plate. So half of it is non-starchy vegetables. 1/4 is a protein and 1/4 is a starch. Also, if they should limit their alcohol intake. Alcohol inhibits glycogenesis from the liver, so they'll go hypoglycemic because the body's not making enough sugar, because your liver usually helps with that. And instead, it's taking over and trying to filter out whatever alcohol you're drinking. So alcohol, hypoglycemia. So they should eat while they're drinking. The miscellaneous, feet are a huge thing with diabetics. Any LPNs or anybody who's working in healthcare fields can tell you this. They have to check their feet daily. They should wear comfortable and protective shoes. Never walk around barefoot. I almost say never even wear sandals, but we're in Florida, so you're gonna probably see a lot of diabetics wearing sandals. They never should cut down the corners of their toenails. They should check the temperature of baths if they're gonna take a bath or wash their feet with the elbow. Never put lotion between their toes. You shouldn't keep moisture between the toes. That will cause skin breakdowns for them and they won't know. Clean with mild soap and water only. That's even if they have a wound. The problem with diabetics is, I remember one story, is someone's dad, I guess, he had a sock. You know, when you take off your shoes, you just shove your socks in there. Well, he still had a sock in there. Well, he put in his foot, and he's a long time diabetic, and he's walking around. It kind of felt uncomfortable, but he didn't think of anything of it. And he took his foot out. He broke like 2 of his toes and had no idea. The neuropathy in these people is crazy. They don't know they cut open their feet. And then they have this huge infection or a huge wound on their foot that will take forever to heal. Most of the time it ends up getting amputated, which is really sad. So feet is definitely a big deal for these people. Like I won't cut, okay, so you do, why? That was weird. So I will not cut someone's toes if they're diabetic, by the way, not their toes, but their toenails. I won't do it. Podiatrists will do that. That's how extensive it is. Exercise. The American Diabetes Association recommends performing at least 150 minutes per week. So that's about 30 minutes, 5 days a week, of a moderate to intense aerobic physical exercise. I don't know which med-surg book you guys use. I use the blue one. That's the 10th edition, I believe. Yes. So there's a nice little chart of the different types of exercises on one of these pages on 1134 that show the moderate activities. So like bicycling, also says gardening, bowling. So 30 minutes a day, 5 days a week, they should do that. Other things you do need to know is before they work out, they should check their blood sugar. If their sugar is 100 or below, they need to eat a 15-gram carb snack before working out because their sugar is too low and it'll drop it even further. Wait another 30 minutes, check their sugar again. If their blood sugar is below 100, too bad, go eat a meal, you're not working out today. And then if it's like 3 times they still can't get their sugar up, they should probably go to see their doctor or something like that. But it is key that they should check their sugar, as well as have a adequate warm-up and cool down during the exercise session. They're welcome to check their sugar in between. It's always advised also to bring a snack when they're going to go work out. Alrighty. So now we are going into diabetic ketoacidosis. So this is when these are acute problems with, I want to make sure I'm going in order. This is acute problems with diabetics. These are life-threatening problems. So diabetic ketoacidosis, this usually occurs mostly to type 1 diabetics because quickly they're out of insulin. This is before they're possibly diagnosed. So some causes or etiologies is poor compliance, undiagnosed type 1s, illness, or lack of insulin supply, which is unfortunately occurring a lot nowadays for how expensive insulin is, and this is why the diabetics are dying. So what's happening is that there's a severe lack of insulin, so then your cells cannot use the sugar, the glucose that's circulating in your bloodstream. It's high enough, you got plenty of it, but no insulin. So the body will do what's going to do. It starts breaking down fats for energy. This is called ketosis. However, the byproducts are ketones. Ketones are very, very acidic. And so it will lead to metabolic acidosis. You guys should already have had ABGs done before. So they will go into metabolic acidosis. as well as to try to fix the metabolic acidosis. Your electrolytes or your buffer systems will kick in. This causes electrolyte imbalances. And during this, think of you're having hyperglycemia. There's a lot of signs and symptoms, but just break it down to what you know you're going to see. So with them, they are going to have super high sugar levels, causing increased osmotic diuresis. So they're going to be super dehydrated, and then as well as they will have fluid and electrolyte imbalances and pH imbalances. You don't fix this, they're going to go into shock, coma, and then death if they do not seek medical treatment quickly. So that is how severe this can occur. So we're going to go into the next slide. Yes. All right, so clinical manifestations. Don't get super overwhelmed. I want you to break it down. So you know they have sugar, super high sugars. So you already know what the signs and symptoms of hyperglycemia is. Polyuria, polyphagia, polydipsia, glucosuria, blurred vision, weakness, nausea, vomiting, headache, as well as in this point, they're going to have acetone breath. This fruity, sweet smelling acetone breath is because there's too much ketones and you can start smelling it. Then they're going to have signs and symptoms of dehydration. You guys have learned that since level 1. Poor skin turgor, tachycardia, dry mucous membranes, confusion, lethargy, orthostatic hypotension, sunken eyeballs, and then as well as they're going to have clinical manifestation of metabolic acidosis. That is Kussmaul's respirations, which I have here on the slide. This is deep and rapid respiration, not shallow and rapid, deep and rapid respirations. And then to compensate, to try to get their acid levels back to normal, because they're acidotic, they'll start having nausea, vomiting, because remember your stomach acid is a high source of acid. So it will try to start vomiting that up to fix what's going on. As well as that's why Kussmaul's respirations are occurring. Try to breathe out that CO2 because they're trying to fix its pH. Some labs or diagnostics, they're going to have low potassium levels most likely, low sodium, low magnesium, low phos, and low chloride. The main one you have to worry about is this low potassium. Their blood sugar levels are going to be equal to or higher to 250. Your pH, again, they're going to be acidotic. So your pH level is going to be less than 7.3. Your bicarb is going to be less than 16, as well as they're going to have ketones in their urine, and they'll test for it, so they'll have ketonuria. All right, I'm going to keep moving. It will let me. Yes, so we got management of DKA. Automatically, you're going to monitor their vital signs. You're going to monitor their level of consciousness. That's what LOC stands for. You're going to have a telemetry box, or you're going to monitor their heart on the rhythm. You're going to monitor their cardiopulmonary stasis, and then UOP is urinary output. You're going to monitor that, and you're going to monitor their labs. So once you get your doctor's orders, the main thing you need to treat is the fluid imbalance. This is the most threatening. They're about to go into shock. This is what's going to kill them first. It's not the sugar, it's not the ketones, it's that fluid. They're at risk for shock. So you're going to do IV fluids, 0.45 or 0.9 sodium chloride with possible electrolyte replacements, depends on how your labs are. And you're going to do that until they have adequate urine output of 30 to 60 ml per hour, as well as when their blood pressure is normal. They didn't give me a number in the book. That's why I didn't put a number here, because it depends where you work on what blood pressure is okay to work with. Before you start insulin, you must check potassium levels. Insulin will temporarily drive K back into the cells. So if you start IV insulin and you didn't check their potassium level, you're just going to cause them to go hypokalemic, and then you're going to be a whole nother mess of problems. So again, you need to check your potassium levels before you start insulin drip. Then you'll start the IV regular insulin. Only regular insulin can be IV, by the way. Key fact. And you're going to start that 0.1 units per kilogram per hour. And then when your blood glucose gets to 250 milligram, I know this doesn't make sense, you're going to start giving them sugar. You're going to hang a bag of 5 or 10% dextrose. The reason for that is because if they become hypoglycemic and then you flush all this fluid in, you're going to cause cerebral edema. So you don't want to take them from one extreme to the other. You got to slowly get them back to the middle and make sure that they don't, go to the other extreme. So again, you're going to start fluids, either isotonic or hypotonic. You're going to do probably electrolyte replacements once you get your labs. You're going to want to make sure they have adequate urine output. You're going to want to check potassium levels before starting insulin. That is in your book, because I remember I was like, well, which one do you start first? That wasn't a problem. Just know that insulin drives potassium into the cell. Then it's only regular insulin that can be IV. And when you start getting to a blood glucose of 250, you're going to start hanging sugar with it too. And a lot of these patients are basically like comatose. They're not with it. The first time I ever tried to put an NG tube was in a patient who was going into DKA in the ER. And it took 3 people just to hold her up because she wasn't even completely with it. But she kept throwing up and she could possibly aspirate. So these people don't look good, typically by the time we're seeing them. Then you have the hyperosmolar hyperglycemic syndrome. So this is, you're just a smidgen away of getting DKA. That's what this condition is. This is more commonly in type 2s because they're type 2, again, they have some insulin, not very effective, but some insulin still circulating. So for this, there's enough insulin that they don't go into DKA. So they still experience hypotension, dehydration, hyperglycemia, but ketoacidosis does not occur. Causes of this can be infection, sepsis, acute illness, undiagnosed type 2 diabetes, or your book said patient may have a history of poor fluid intake or impaired thirst mechanism, AKA that's basically elderly people. They do not drink enough fluids and they don't know when they're thirsty. So the elderly is most at risk for this. The signs and symptoms, again, you're going to see signs and symptoms of dehydration and hyperglycemia. The extra portion is more neurological focus. This is because the blood sugar levels are so high and your brain cannot handle it. They're going to be aphasic, and you guys haven't had stroke yet. So I apologize, I will explain these terms. Aphasia is a difficulty expressing. Like you'll talk to them and they'll just keep looking at you and keep trying to find the words, but they can't. Seizures, somnolence, and hemiparesis, that's where you see one side of the face is paralyzed or one side of the body is paralyzed or lost its function. Those are signs and symptoms of a stroke. So a lot of times when someone's having stroke symptoms, before I call a doctor, I get a blood sugar because they could be hypoglycemic or having one of these episodes. So there are neurological changes when it comes to HHS. Your blood glucose will be sky high, 600. Luckily, I've not seen that, but 600 milligrams per deciliter. And the reason why it got that high before anyone noticed that it got that high is because there was enough insulin that signs and symptoms didn't kick in until it got to this point. They will have no to minimal ketones in blood or urine. Key point, because DKA has tons of ketones. Management of this, same thing. Monitor vital signs, LOC, cardiac rhythm, cardiopulmonary status, urine output, and labs. And guess what? Your treatment is basically the same thing. IV fluids, enough to restore urinary output. You're going to monitor blood glucose when it gets about 250. You're going to change them and have some sugar along with the IV fluids. You're going to check potassium levels and start IV regular insulin. Ooh, any questions about these two? While I take a breath. Okay, go ahead.
So the hyper or smaller hyperglycemic, the one that you just said, is that the same? You said it's the same, or is before you get to the ketoacidosis?
No ketoacidosis occurs. There's just enough insulin that it prevents that. Your treatments are basically the same thing. That's what I was saying was the same. It's just the treatments.
Oh, okay. Yeah.
All righty then. Okay, gonna move on while this works. All right. So now we're gonna go into treating hypoglycemia. Because we already went over the signs and symptoms. Again, shaky, cold, and clammy. Give me some candy. I promise you that will save you several times because it did for me. So if your patient is unconscious, please do not be shoving things in their mouth, down their throat. You're going to do sub-Q or IM glucagon. After you give them that, please turn them on their side. That rapidly releases sugar from the liver, which causes GI upset, and they may vomit, and you really don't want them to aspirate, so turn them on their side until they become alert. Or you can do IV glucose. Usually the IM glucagon, a diabetic would carry that around. IV glucose would be more on like the hospital setting that you see. If they are with it and they are talking to you, you are allowed to do the rule of 15. So if they have a blood sugar level below 70, you're going to do 15 grams of quick acting carbs. You're not going to do candy. You're like not candy bars, not cake, not ice cream, nothing with fat. You're going to do 4 to 6 ounces of regular soda or OJ. You can give them hard candy, 1 tablespoon of honey. There's like a few more examples in your textbook, but those were mostly the ones that I could see. Again, no candy bars, cookies, whole milk, or ice cream because the fat delays absorption. And this is when you just want to get their sugar up quickly. Then you're going to wait 15 minutes. CBG is capillary blood glucose. So you're going to check the CBG again. And then if it's, again, below 70, you do a repeat of the 15 gram of carbs. Then you wait 15 minutes later, check it again. Hopefully it's within normal limits. That's what WNL stands for, within normal limits. Once that occurs, if they're not eating within the hour, you give them another snack, a carb with a protein or fat, which is crackers with peanut butter or cheese. Again, you don't do this until their blood sugars are better, as well as if they're not going to eat within the hour. If you do the 15 grams of carbs like 2-3 times and you're not getting a sugar above 70, you start calling a doctor. All right, so that's for hypoglycemia. So now we're getting into chronic complications. So the reason why diabetes is super bad is because it doesn't just affect your blood vessels or affect your stomach from poking yourself with insulin so much. It's because this does cause death, limb loss, and blindness. High glucose levels in circulation is damaging to nerve and blood vessels. You need to know the difference between the macrovascular versus microvascular. Macro are the larger vessels, so your cerebrovascular, they're a high cause of strokes, diabetes is. Cardiovascular, diabetes will cause hypertension. And PVD, which is peripheral vascular disease. That's poor blood flow in your major limbs. Microvascular is your eyes, so retinopathy, kidneys, nephropathy, can't say that very well, sorry. And then nerves, which is neuropathy. A lot of patients have neuropathy, and neuropathy is more than just numbness and tingling in their fingers. It goes all the way to like their bladder. They may not be able to feel when it's full, and then they get neurogenic bladder, and then they're incontinent for the rest of their life. As well as if they're having a heart attack, diabetics actually are more prone to having silent heart attacks because of the nerve damage that's occurred. So they don't feel it. Diabetics with type 2, if they have, by the time when they are diagnosed with type 2 diabetes, they should have a dilated eye exam. When they are diagnosed, like within like the few months that they are. Then every year they need to have another dilated eye exam. Patients with type 1, within 5 years, they should be get an eye exam. And then after that, annually. Okay, so it is very important for them to get their dilated eye exams. And that is my reference, which is my 10th edition med-surg book when I was in school. Okay, so who has questions or, yep, because we're at 6 o'clock now. Does anyone have any questions for me?
Can you do the same for the other chapters too?
It's mostly like whoever,
That would be
whenever
awesome.
Yes, we would love to. We can do another one like this, but for the other chapters too.
Yeah, you should be lecturing our lectures.
Thanks, guys. It just kind of depends on what Lisa asked me to do or what you guys need. Diabetes is a lot, but I've done this frequently. I used to be on campus, so I guess it's whatever till your, basically the chair will ask Lisa what workshops they can do, or we figure out what workshops. So comes and goes.
If we had a survey to fill out, that would be awesome because you would get all the best of points.
Thanks. I don't know how we're doing surveys anymore. We used to, but for right now, I'll just tell Lisa, or you guys can email Lisa and just say, could we have more of this? And then they'll make more time. Because I just do this part-time for now for fun. Any questions for diabetes? I know I went over a lot. And you guys' exam is Tuesday, is that correct?
Monday.
LPNs is Tuesday, Monday for level 2?
Yes.
Okay. All righty then. And then did everyone do their student number?
Yes. I did mine. I don't know the rest.
In the chat. I'm gonna have that up there. Hopefully this is still, yes, this is still recording. Okay, last time it kicked me out and stopped recording in the middle of it, so that really sucked. Okay, so if no one has any questions for me, I will try to see how I can get this PowerPoint uploaded. It would unfortunately have to be approved by the administration, so that could take a while. And unfortunately, I cannot hand it out because I'm no longer a student. Before, I used to make PowerPoints and send it out, but I can't anymore because now I'm part of staff. And not
So
student.
where do you work now?
I work at Baycare St. Anthony on a med surg.
Nice.
But I will
Nice.
be moving to Kentucky, still doing this online, working on a trauma floor.
When are you moving to Kentucky?
July, next month.
Good for you. My family is in Louisville, Kentucky.
Oh, I'm going to Lexington.
I know where Lexington is because I have family in Lexington too. So
Oh, nice. Yeah,
yeah, I love
I know they have
Kentucky.
a big rivalry. All right, guys. So, and this should be recorded and uploaded somewhere as well. So if no
Okay.
one has any more questions, we're going to end this session. Thank you guys for coming. Okay.
Thank you. Good luck in Kentucky.
Thank you so much.
You'll be saying "Go Wildcats" in no time.
That's what everyone. They already sent me stuff. Where?
My cousin teaches over
Thank you.
in Louisville, but he
No
teaches
problem.
medical school there. So
Okay.
you'll love it. You'll love it. But have a great day and nice to meet you.
Thanks, guys. I'm leaving it up because I'm writing down from the chat. So you guys are welcome to exit. Thank you. 5, 8.